We're going to talk about iridotomy and iridoplasty. The laser has been a huge boon to those of us who take care of glaucoma. Iridotomies and rarely surgical iridectomies are designed to eliminate pupillary block. So you don't do it on everyone who's got any kind of angle closure. It needs to be a pupillary block form of angle closure. Pupillary block. Surgical iridectomy is rarely performed as a standalone procedure. It's done with trabeculectomy many times. The only time that I've ever had to do surgical iridectomy is in somebody who is mentally challenged and unable to sit through a laser iridotomy. Prophylactic iridotomy indications would be high pressure with appositional angle closure, more than 180 degrees of apposition, and these all are a little bit soft. If one has an angle that's narrow and there are areas that have synechia, that would be an indication. History of acute angle closure glaucoma in the fellow eye. Other risk factors like a positive family history, narrow anterior chamber depth under 2 millimeters would all be things that would make one drift towards a prophylactic iridotomy. Pigment dispersion syndrome in very selected cases, and we'll talk about that in the pigment dispersion syndrome pigmentary glaucoma lecture. So the idea is that there is pupillary block, the iris is bowed forward, and the fluid behind the iris is driving it forward. One makes a hole in the iris and the fluid comes out into the anterior chamber, reestablishes that flow between the posterior and anterior chambers, and lets the iris fall back, hopefully uncovering the trabecular meshwork, unless the iris has been forward so long that it's now synechically closed. One can do these superiorly or within the palpebral fissure, which is what I prefer. If it is done superiorly, it needs to be completely covered by the upper eyelid. The time people get into problems with visual symptoms is when the eyelid is just at the iridotomy. The tear meniscus forms a prism and gives people a difficult time with extra images, white lines across their vision, for example. I prefer the temporal location, as in this patient here, and have not seen visual sequelae from the temporal location. Seems counterintuitive, I know. A recent study in 2014 confirms that there are fewer dysphotopsias with temporal placement when compared to superior placement. Patients are pre-treated to prevent pressure rise. Bromonidine is typically used, and then the iris is put on stretch by giving the patient pilocarpine. A topical anesthetic drop is used. I always use a condensing lens. I would highly recommend that. This increases the energy delivered to the iris and decreases the energy delivered to the cornea and the retina. So the Abraham lens is 66 diopters, and the Weiss lens is just more of the same, 103 diopters. This is the lens that I prefer, although it's much easier to get lost with the Weiss lens. One has to be very careful of the landmarks because it magnifies so much. In pigmented irides, I like to use 50 micron spot, as much energy up to a watt as I can get out of my laser, and I like very short delivery time. I use 0.02 seconds, and I use a Weiss lens that, in this combination, to me almost makes the iris vaporize. There's not stretching and movement of the iris tissue. The Academy's Basic Science book uses similar settings but a much longer duration of 0.1 second. And then once I get through the stroma down to the pigment epithelium, I will usually move the patient to the YAG laser, which in our case is in the same room, and just use a very low power just to clear the pigment epithelium away. In light-colored irises, one can use the argon laser to pre-treat in order to prevent bleeding. I find it not to be very helpful. In the blue eye, I would typically skip the argon laser and go right to the YAG laser. And with the Weiss lens, I use fairly low power with the YAG laser. Afterwards, I treat the patients with prednisolone 4 times a day for 7 days. The goals here are obviously to eliminate pupillary block, but also to have an iridotomy that's obviously open on follow-up. So the one on the left is open, but it's hard to tell that it's open when one looks at it. The one on the right might be a little on the big side, but it's clearly open with the slit lamp. You can look through it and see the lens capsule. I don't think transillumination counts because one can transilluminate through iris tissue, so I don't personally believe that that's a very good way to assess the patency of an iridotomy. Complications, the pressure can go up, so we would usually see the patients after an hour. They can have bleeding, particularly with the YAG iridotomy, but it's usually short-lived and one can stop it with pressure on the lens. Inflammation, so this is a person who was on pilocarpine at the time that they had their iridotomy, and the pilocarpine and the inflammation together cause this ring of posterior synechia. One can get corneal burns, particularly if the iris is very, very close to the cornea. And photopsias we've already talked about. It's important to know that the angle deepens, but it doesn't get deep. It's not, these people suddenly don't have deep angles like myopic patients. They still have small eyes and a relatively large lens for the size of their eye. This is just an example. This is a patient before and after laser iridotomy. You can see that by Van Herrick, the angle is very narrow. There's the iridotomy that was done with the YAG laser. And then afterwards, the angle is deeper, but it's not deep. It's not a grade 4 angle. And because of that, one needs to do serial gonioscopy to monitor the angle even after the iridotomy. Because as they age and their lens gets thicker, they could develop a phacomorphic component on top of this primary pupillary block. These rarely close except in inflamed eyes. Shifting gears to iridoplasty, the iridoplasty is designed to pull the iris out of the angle to shrink the ciliary body back in plateau iris syndrome. It can be done with or without a gonioscopy lens, delivering burns into the very far periphery of the iris. These are the opposite of iridotomy. Iridotomy, one wants a very small, fast, high-intensity burn to penetrate the iris. In this, we want slow, low-power fat burns that just cause the iris to shrink but don't penetrate. So in the range of 200 to 500 microns, long duration, 0.2 to 0.5 seconds, relatively low power. I find that I don't do that many iridoplasties. I see some people with plateau iris syndrome, but I see fewer than I guess others do. So the key points here, iridotomy is designed to eliminate pupillary block. One can use an argon and or a YAG laser, and it has few complications.